Dr. Chris Harle is an associate professor in the Department of Health Policy and Management at the IU Fairbanks School of Public Health. He is also an investigator at Regan Street Institute Center for Biomedical Informatics and an associate faculty in the Kelley School of Business. He holds an MS in Decision Information Sciences from University of Florida's Warrington College of Business Administration and a PhD in Information Systems and Management from Carnegie Mellon University's H. John Heinz III College. Dr. Harle's research focuses on the design, adaptation, use, and value of health information systems. His primary interest is in understanding how information technology-mediated communication tools affect consumer, patient, and provider decisions and behavior. Recently, with funding from Pfizer, the National Institute of Health, and the Agency for Healthcare Research and Quality, his research has focused on developing clinical decision support tools to support primary care physicians in chronic pain care and opioid prescribing. Please help me in welcoming Dr. Harle.
Good morning, everyone. Thank you, Robin, for that introduction, and thank you, Mr. McClellan, for that wonderful overview. I'm going to dig a little deeper and more narrow with my talk here, and I'm going to use some slides, so thanks for bearing with me on that. I'm going to talk about opioid prescribing from the perspective of chronic pain care, from the perspective of primary care clinicians and others who are out there on a day-to-day basis trying to take care of patients, all while in the context of this larger public health and opioid crisis. I will acknowledge a couple of funding sources here, federal sources including the NIH and the Agency for Healthcare Research and Quality, and of course my comments are my own and not theirs. I'd like to start by putting ourselves into the minds of a busy primary care doctor, and I've interviewed many of these over the course of the last 5-6 years. These are people who are seeing complex patients, patients with complex chronic pain conditions, other challenging chronic diseases, and they're seeing those patients often in 5, 6, 7, 8-minute visits. And so when you talk to these clinicians about opioid prescribing, you talk to them about chronic pain, they say things like, you know, I would say the vast majority of people, I get a good feel for it. But then they admit, you know, I've been snagged a few times. I thought the patient was being honest with me. And then they kind of go on to admit things like, you know, I guess you can't be right 100% of the time. And sometimes you're probably erring in not giving a patient medication when they truly do need it. And other times you're probably erring in giving patients medications when they don't need it. And I start with this because I think this is one of the fundamental challenges from the clinical side of things that clinicians have been facing, prescribers, physicians, and other prescribers have been facing for several years now, is this investigation, this trying to solve this problem. Do I prescribe or do I not prescribe? And it's complicated, right? It's not as simple as stopping opioid prescribing. It's not as simple as, certainly not as simple as giving more and more opioids. So I'll continue to bring up some of these vignettes as I go through. I'll start also by saying I'm not a clinician, I'm not a physician, I'm not a nurse, I'm not another clinician. I'm an information scientist, and I study the kinds of questions you see here on this slide. I'm interested in how doctors, other clinicians, and their patients interact during visits. I'm interested in what information is missing, what tools are missing that could help a clinical interaction, could help drive more evidence-based care, could help drive care that's safer and more effective. And we talk to a lot of clinicians about where their struggles are, and we talk to them also about information technology. And so as we talk more today about prescription drug monitoring programs, that's one example of an information technology, of an information system that can be helpful in this larger opioid crisis. So much of my work focuses on electronic health records, right? These are essentially ubiquitous now in our healthcare system. Most every physician and other healthcare provider is working day to day with an electronic health record. Many of them don't like their systems. There's room for improvement, room for developing systems that are better at getting the information in the hands of the clinicians, the information they need when they need it for the patients that need it. And so much of what I do is ask, how can we make these systems better? I won't spend too much time here because I think we've already had a nice overview and many people in the audience already know that the pain is real, right? We've seen the recognition of pain as the fifth vital sign. We've seen the aggressive marketing of opioids and the massive amounts of prescriptions over the last 25 or so years have led to widespread misuse, abuse, and diversion. Today, as we all know, we have in this country over 30,000 overdose deaths. And as a bit of a sign of progress, as Mr. McClellan pointed out, we have seen opioid prescribing go down. We have seen decreases in high-dose opioid prescribing in recent years. They're still much higher than they were decades ago. But now we're seeing the increases in illicit opioid use, and these are just as problematic, of course, as prescription opioids. So this is sort of where we're at today. But I still think it's important to ground ourselves in the real problem of pain, both acute but also chronic. We have an estimated possibly 100 million people in this country with chronic pain at costs of $600 billion annually in healthcare and lost worker productivity. This is a massive, massive, costly problem and a burden on our communities and a burden on our healthcare system. We know we have 11.5 million people misusing opioids and nearly 2 million people with an opioid use disorder. And this problem becomes very acute when you think about, again, that primary care physician or that nurse practitioner who's taking care of these patients. Where do patients go when they have pain? They go to their primary care doctor. We have 28,000 patients with pain for every board-certified pain specialist. So they're not all getting specialty care. They're going to a primary care doctor. And I think primary care encounters are contextualized by all of these things, and I think these factors also extend to other clinical scenarios, emergency departments and hospital medicine in some cases. But clinicians have limited knowledge in many cases. Pain, chronic pain, is complex, it's biopsychosocial, and medical school doesn't cover that. The medical school, you're lucky if you get a couple of lectures on pharmacology, and I think some of that's changing now, but still, physicians are not prepared for the complexities of pain and chronic pain that they see on a day-to-day basis. So limited knowledge, limited time. We've all heard and talked about the quick, rapid-fire primary care visits. How do I take care of a patient's chronic pain, hypertension, diabetes, and actually just understand what's going on with them in a very quick visit? Incredibly hard. Incomplete information, and I think this is one of the places where Inspect and the integration of Inspect with EHRs can help. Our information systems are fragmented. Our electronic health records don't have all the data at the fingertips of the clinicians as they need to make important decisions about prescribing or not prescribing. We have limited non-opioid options that we know are there to treat pain and will treat pain effectively. And this all leads to some really challenging patient relationships and some really challenging interactions between a doctor and a patient. Patients with chronic pain report all sorts of stigma. They report they don't like going to the doctor, and this is only getting worse. Physicians don't like taking care of patients with chronic pain. It's hard. They don't have the tools they need. They don't have the information they need, and these patients have, in addition to their pain, oftentimes complex mental health, substance use challenges. Here's another example from an interview I did a few years ago with a general internist. She said, I did a couple of urine screens and things like that, and I was a little uncomfortable, but she was a patient for a long time. If I didn't give her pain medicine, she'd end up in the emergency room. Anyway, it was recently I found out she came into the hospital and she was positive for cocaine a couple of times. And I was like, oh, sometimes I don't know how to manage patients effectively. So again, these are the challenges that our doctors are seeing on a day-to-day basis. Really challenging patients. She continued on to say, she's been my patient a really long time. We've been through a lot of things together. And in some ways, you really like that because you like to think of an ongoing, trusted relationship between a doctor and a patient. That's, I think, what we want in our healthcare system. But in this case, it creates even bigger decision-making challenges. It creates real struggles. She saw red flags. She saw signs of risk on this patient's urine drug screen, but she also believed that the patient had a real pain condition. And then, at some point, probably not as soon as she wanted it, she found out, oh, this patient's been in the emergency department and was positive for cocaine. And as many of clinicians know, that information may have not gotten to her as quickly as she wanted it to, and therefore she wasn't able to respond as quickly as she could have. But the pain is real, the challenges are real on a day-to-day basis for clinicians as they try to take care of these patients. I like to think of this concept of information chaos. This was coined by some researchers about 6 years ago in describing a primary care doctor's office or a primary care environment. Characterized by information overload. There's a lot of information flowing through now that we have electronic health records. Oftentimes, however, that information is scattered, not easy to access. Oftentimes, it's erroneous, it's out of date. When we think about opioids, we think about patients perhaps reporting things that are inaccurate for various reasons. In other cases, we have information underload. While we have massive amounts of data and documentation in our electronic health records, we may be missing key pieces of information that help a physician assess risk, assess the benefits of a medication they're going to prescribe, and really get down to the point of how can I help my patient? What can I do to help my patient? So this chaotic environment is something that we're going to continue to live in as we get better with information technology and as electronic health records and exchange of information becomes even more ubiquitous. But now the question becomes, how do we boil that information down and deliver it to the clinicians and deliver it to the patients when they need it, in the form they need it? So let's talk about PDMPs a little bit and the integration into clinical practice. I'll go very briefly over evidence on the effectiveness of PDMPs. Many states now have, essentially all states have PDMPs now, and they've all used them in different ways, but they've put out several reports. Doctor shopping has decreased. Controlled substance prescriptions have decreased. We've seen this in Indiana. Fewer controlled substances being dispensed, reduced costs around drug investigations and diversions. So there's plenty of good reason to believe that PDMPs work and are part of the solution, one piece of that solution that we've been talking about. I will put my researcher hat on for a minute and say more work is needed. I don't know that we fully know exactly how effective PDMPs are for several reasons. We don't have larger multi-state national studies. And it's also really hard right now to know exactly what the effect of a PDMP is because we are throwing so many different interventions at this problem, right? States are implementing not only their prescription drug monitoring databases, but they're implementing policies around prescribing limits. They're implementing other chronic pain guidelines and so forth. And so all of these are going towards this problem. And so exactly what the role of the PDMP is, we're not sure. But I think we can all agree with reasonable amount of evidence that these are good tools to have and they're part of the solution. Interestingly, the Training and Technical Assistance Center out of Brandeis University for PDMPs, they put out a series of best practices, suggested best practices for PDMPs. I've only listed 6 here, and I'll highlight 3 of them in particular. There's a much longer checklist. And in parentheses, what you see here are the percentage of states reporting currently that they do these. So 93% of states say that they allow delegate accounts. What does that mean? That means that a busy physician can delegate a member of their care team to look up the report, right? A nurse or someone else to help them in their workflows, and I think that's pretty important, and most PDMPs do that. Engaging in interstate data sharing, enhancing reports with things like morphine milligram equivalents of opioids is another suggested best practice. But then when we get down to these last 3, which I want to talk about because I think they're very relevant today in Indiana, and they're not as widely used, is the integration of PDMP reports with EHRs, the integration of PDMPs with health information exchanges, and the provision of user-friendly interfaces. In other words, decision support or risk scores. And what these are really getting at is making the use of the data for those busy, challenged physicians and other prescribers, making it as easy as possible to access, review, and make a good decision for their patient. We see only around 26% of other states are reporting the use of these best practices. Here in Indiana, as we heard, we're on our way to integration with EHRs, which I think is fantastic. Here in Indiana, we have a long history of health information exchange that is broader and more comprehensive than most any other state in the country. And we have a history of integrating our PDMP with that health information exchange. I think the next step is going to be those user-friendly interfaces, and I'm going to talk more about that. Again, on the side of EHR integration, only 26% of states are reporting integration. All the way back as early as 2012, 2013, there were several federally funded pilot initiatives, including initiatives, 2 of them here in Indiana, 1 in Indianapolis, where in collaboration, Eskenazi, which was Wishart at the time, the Regenstrief Institute, the Indiana Health Information Exchange got together, and they recognized this problem, and they were funded to start putting prescription drug monitoring data in the day-to-day workflows of emergency department physicians. And by all accounts, that was really valuable. And so as we move towards, and we've seen the pilots, and we'll hear more about them, I'm sure, on our panel, Kroger and Deaconess and others are signing on and moving through over the next few years. I think this statewide rollout is impressive and puts Indiana out at the forefront of this work and really important. So here's a quote from an Eskenazi physician, kind of hearkening back to the original integration that we did here. And he or she was saying, InSpect is kind of a pain to look at because it's not well integrated into what was their new EHR when this quote was taken. So what do? I Google InSpect, I log in through the internet, and I look at it there, and I put the information back in my EHR. And okay, maybe you say that's not too hard. Anyone can do that. This is an important problem. We need to take the time to do this. And that's arguable. At the same time, there are workflow impediments that prevent this. And so this clinician said, we used to have connectivity, but people noticed when it went away. And I think this, again, just underscores the real importance of this EHR integration that we have coming statewide. Other clinicians say, it would be super nice if InSpect was available in the EHR or the EMR. It's a great thing. I wish I had more time to use it. But at the end of the day, it's one more thing that you have to do. You tend not to do it, right? And that can be hard to hear because in some ways you think, this is so important. The opioid crisis is so important. We have to look at this. But when you think about busy workflows, if it's not easy to do, if it's not easy for the clinician to get at, sometimes they don't do it. So EHR integration, I think, is wonderful, and the faster we can do that and the more efficiently we can do that, the better. But let's talk more about this idea of user-friendly interfaces, because I think we can do more. I think we can do more than just putting a PDMP report right in your EHR. It's a major hurdle to be able to, when you have a patient's record up, click a button and see the patient. That's a great hurdle to overcome than having to go out and Google InSpect and search and so on. That's fantastic. However, I would challenge us to say, how can we make information even easier and more convenient? How can we start to integrate the PDMP data with other clinical data that helps doctors make those really challenging decisions, right? Because it's not as simple as, oh, this patient's clearly high risk, there's no way I'm prescribing, or this patient is clean and clear and I should prescribe. So how do we put relevant information in a single place? How do we make sure we're using validated risk assessments? So if our system is telling us that this patient is at risk of misuse or abuse or overdose, we feel confident in that assessment, and that's not always a straightforward question. And how can we make information actionable? Busy physicians and other prescribers want actionable information. They can't be overwhelmed with massive amounts of data that they have to parse through on every single patient. And in some cases, that's what we see in PDMP reports, right? And we're getting better. We're making these interfaces more user-friendly. InSpect has become better at this already. But in many states, and still here I think in Indiana we can do better, what's a PDMP report? It's a line-by-line reading of every prescription that patient has had, and that can be complicated and difficult to parse through. Ultimately, what we want to drive towards is helping clinicians ask these really critical questions. Does the opioid prescription benefit outweigh the risks, or vice versa, and therefore, should I prescribe or not? If not an opioid, what do I do? How do I treat their pain? And there are lots of other evidence-based pain treatments, but there's also a lot of different pain etiologies and different types of conditions, and clinicians need help figuring out how to sort through those. And then, of course, as we see this massive uptick in substance use disorder and addiction, how do clinicians get the information they need to get patients into the treatment they need for those? So that's, I think, what we need to start moving towards in addition to having the PDMP data available. This gets us back a little bit to that initial vignette, but I think it summarizes it again nicely. This was another physician who said, you have the patient who definitely need the medications, you have the patients who definitely don't need the medications, and then you have the really tough management cases. And these are the ones that challenge the physicians, that take their time, that stress them, that back up their clinic schedules. They're difficult to assess whether or not they truly do need the medication. And so helping them make that decision in a way that's evidence-based, in a way that's validated, is fundamentally important. I think we can also think about this problem in a larger context. We have a fragmented, hard-to-use set of health information systems, both here and around the country. These are some of the themes that have come out of a whole series of interviews we've done, in addition to InSpect being hard to access and review, which we're making progress on, which is great. But opioid treatment agreements not being accessible, no easy place to understand what a patient has, what their history of medication treatment is, what their latest refill was. Hard challenges in getting emergency department or hospital information. How does a primary care doctor know that their patient has been to the hospital and know that they've been to the emergency department? That's often not available when they need it. Hard to get treatment rationale from other clinics. You have these complex patients who are going to specialists, who are possibly going to other primary care providers. It's not always straightforward to know what they were doing and why they were doing it. And in some cases, hard to access mental health records. So we have this very fragmented, siloed information environment that creates that chaos that we talked about earlier, and we need to overcome that both with medication data, PDMP data, but also the larger context of healthcare data. Here's just a potential solution. This is something that my team and I are working on to rationalize chronic pain care and rationalize chronic opioid therapy when it's appropriate. We call this a one sheet. It's basically meant to be a one-stop shop that you can put in your electronic health record to bring all of the information that guidelines say you need, that state law says you need to appropriately prescribe opioids. It has risk assessment built into it. It has information about patient outcomes. Are they actually getting better? Do we see improvements in functionality? Because that's ultimately what we're trying to do. It has, with the integration that we're seeing with EHRs, it will have integration with Inspect. It will make it easy for a clinician to order the urine drug screens that they're supposed to be doing and hopefully interpret those urine drug screens appropriately. So this idea here is those user-friendly interfaces that we need to move towards to make patients' and clinicians' lives easier and help them be more effective. So as we move towards conclusions and summary here, I think combining PDMP data with EHR data is critical, not just integrating the PDMP next to EHR data, but allowing us to do analytics on the PDMP data alongside of diagnosis data and other historical data. We need simple, validated interfaces. We need strong collaborations and partnerships with EHR and IT vendors. And then, of course, as always, we need to be asking, is this investment worth it? Is the investment in these integrations, is the investment in the PDMP and all of the other policies and programs, are they worth it? Are we seeing the outcomes that we need to see in terms of efficiency, effectiveness, and most importantly, in terms of the health of our communities? So I'll summarize by saying the pain is real. We all know that. That's why we're all here today. PDMPs are absolutely promising tools, and integrating them into EHRs, which Indiana is doing, I think is wonderful. But as we continue on, how do we make these data more effectively easy to use, more useful to our clinicians? And I would kind of leave you with a quote from Thoreau, which is simplify, simplify. We have to make these data as simple and usable and easy for clinicians to work with their patients. Thank you very much, and I look forward to the remainder of the panel.